Good morning, good afternoon, and good evening. You're watching Medicine with Dr. Moran. I'm Dr. Keith Moran. In this video, you will learn why screening colonoscopy is important for your health. Colon cancer is the leading cause of cancer death in non-smokers in many parts of the Western world. Colon cancer is a highly preventable disease. Most colon cancers arise from precancerous polyps known as adenomas. Adenomas are common, occurring in about 30% of men and 20% of women. Most colorectal cancers arise from these precancerous polyps. The progression can take more than 10 years, but this is very variable. Removing these polyps during a procedure called polypectomy while we do a colonoscopy will prevent colon cancer. The colon is the very end of the gastrointestinal tract. It's approximately 80 centimeters or 3 feet in length. The colonoscope is inserted at the rectum and advanced through the different segments of the colon to the end, which is called the cecum. At the cecum, one can see the opening into the appendix and the opening into the end of the small intestine. The colon is often called the large intestine. Colon cancer can occur at any point from the rectum all the way around to the cecum. While the picture here shows the shape of a colon like a question mark and relatively straight, it can be much more twisty or redundant due to its mobility within the abdomen. This can make it difficult to get the scope all the way to the cecum. Typically, colonoscopy completion rates will be over 98%. What I'm specifically going to talk about today is what we call average risk colon screening. Average risk colon screening refers to patients who are not at high risk of colon cancer. Average risk patients have no risk factors that would put them in a high risk category. And this is the majority of the population. Patients at average risk for colon cancer typically have a 5% risk of developing colon cancer during their lifetime. Patients at average risk of colon cancer are patients without the following: no personal history of precancerous polyps, no colon symptoms such as blood in the movements, change in bowel habits, abdominal pain, weight loss, iron deficiency, no personal history of inflammatory bowel disease, which is ulcerative colitis or Crohn's disease, no family history of colorectal cancer or advanced precancerous polyps, no family history of any genetic syndromes that might cause colon cancer, no history of abdominal radiation for childhood cancer. This chart shows the ages at which colon cancer are usually diagnosed. Please note that there's a significant increase over the age of 50, and this is why it's currently recommended to screen people over the age of 50. Some humor from broadside cartoons. Screening at 50 years of age for average risk patients are recommended by most professional society guidelines, which include the American College of Physicians, the American Academy of Family Physicians, the Canadian Task Force on Preventative Health, the United States Preventative Services Task Force, and numerous other organizations. Some groups have recommended to start screening earlier at age 45, particularly among African Americans who have a slightly higher incidence of colorectal cancer. Data to support screening at age 45, though, are limited. There are many tests to screen for colon cancer. The main two tests that average risk patient gets are either a colonoscopy or fecal testing for blood. In parts of the world, fecal testing is recommended, and in other parts, colonoscopy is recommended. There are risks and benefits of each, and obviously choosing a screening test is better than choosing no screening test at all. The different options should be discussed with your physician. Possible screening tests are the following: colonoscopy. A normal colonoscopy is done every 10 years. Fecal immunochemical testing, which assesses for the presence of blood. This is known as a FIT. Countries which this is utilized as the primary form of screening for average risk patients are many, and typically it's done every year or every second year. CT colonography, otherwise known as virtual colonoscopy, every 5 years. Sigmoidoscopy, which is a partial colonoscopy looking at the rectum and sigmoid, every 5 years, plus or minus fecal testing as well. Stool DNA testing. Capsule colonoscopy, where a capsule is swallowed, which takes numerous images as it courses through the colon. Those images are sent wirelessly to a computer for offline analysis. I will not review the other tests other than colonoscopy and FIT in this video. There are many tests for screening, but the best test is a colonoscopy. It is not just a diagnostic test, but it allows us to carry out therapeutic interventions during the procedure, such as removing polyps, cauterizing lesions, biopsying the colon, or tattooing lesions for subsequent removal. The most important point of a colonoscopy is to find precancerous polyps. Polyps are growths on the colon, some of which will ultimately turn into cancer. The idea is to remove these polyps with a technique called polypectomy before the polyp turns into a cancer. By removing these polyps, we reduce the chance of the polyp turning into cancer down the road. With all the other screening tests mentioned on the previous slide, if they are abnormal, a colonoscopy would then need to be performed. These are some of the findings that we can see in a colonoscopy. On the left, there's an image from one of my recent colonoscopies demonstrating a small tubular adenoma. This is a small 5 mm adenoma. It looks like a bump on the wall. Polyps come in all kinds and appearances, both large and small. Sometimes they look like a cauliflower, with the head of the lesion being the adenoma and a normal stalk. In this image, there's also evidence of diverticulosis. These are small outpouchings on the colon which occur because of increased pressure within the colon. They occur with aging and they can collect stool. They can be quite thin-walled, and if the scope goes up into one of these inadvertently, a perforation can occur. They can collect stool, as you can see in this picture. That's the diverticulum and a piece of stool. Patients with diverticulosis are more difficult to prepare and may require more prolonged preparation. On the right is an image from a recent patient of mine with a nearly circumferential growth inside the colon, which is mildly obstructing the colonic lumen. There is central depression with ulceration, and I can tell you that the tumor was hard on biopsy. Also, the colonoscope was not able to go through this area because it was narrowed. This means that stools or feces will have difficulty passing through, and patients typically present with abdominal pain and constipation and bloating. The purpose of screening is to try to detect lesions early, such as the small adenoma, so that it doesn't turn into a large lesion which is clearly a cancer at the time of colonoscopy. Other tests that have been proposed to screen for colon cancer have poor detection rates. For example, fecal tests such as the FIT will only detect 80% of colon cancers, 40% of early colon cancers, 25 to 40% of advanced polyps, and much less for smaller polyps. This test does not prevent colon cancer, it only tries to detect colon cancer early. Colonoscopy detection rates are approximately 99%. The miss rate for adenomas greater than 1 centimeter is 2%, 13% in the 5 to 10 millimeter range. The miss rate is 25% for tiny 5 millimeter adenomas. It's important the bowel is well prepared. It's easy to miss small polyps if the bowel is poorly prepared. So if you're going to have a colonoscopy done, make sure that you follow the instructions carefully. A well-prepared colon makes detection rate much easier, and it also makes it easier for the colonoscopist to go through the colon and navigate to the very end. So a good prep speeds up the time for the procedure. Colonoscopies do have risks. There have been multiple studies looking at complications over the last 20 years. Serious harm is approximately 0.2% in one meta-analysis. A meta-analysis is a technique of putting together research studies by using different methods to combine similar studies to draw an overall conclusion. Serious harm in this meta-analysis was related to post-procedure bleeding or perforation. In the vast majority of instances, this was seen only when a polyp was removed. Commonly quoted risks are approximately 1 in 2,000 of perforation, 2 in 1,000 risk of postoperative bleeding, typically secondary to polypectomy, and death 3 in 100,000. Risks are obviously much higher in older patients who would have other medical conditions such as heart failure, chronic lung disease, stroke, or cancer. The risks related to sedation are very uncommon. The bowel preparation itself can cause side effects including nausea, vomiting, bloating, and rarely fluid or electrolyte abnormalities. Studies have been done which demonstrate that total colonoscopy costs are actually less than doing the less expensive FIT test when treatment costs of colon cancer are factored in. Colon cancer treatments cost approximately $100,000 to $200,000 per patient. While the upfront cost of a colonoscopy is more than FIT, when one factors in the treatment costs of colon cancer in terms of total costs, it's actually cost effective. This is a disease which is far cheaper to prevent and treat. If we compare colonoscopy screening to other interventions such as medications for high blood pressure, breast or cervical cancer screening, these costs are less than for screening colonoscopy in terms of quality-adjusted life year. In a Swedish study published in the British Journal of Surgery, screening strategies of colonoscopy versus FIT were compared from an economic perspective. While all screening strategies were cost-effective, repeated or even single colonoscopy strategy was more cost-effective when everything was considered. These are some of the results from the studies. Some countries in the world have colonoscopy-based screening of average-risk people at 50 for colon cancer. Studies have demonstrated a significant drop in new cases of colorectal cancer in countries that do this. In Massachusetts, for example, public statistics on the incidence of colon cancer dropped 53% between 2001 and 2016, and this was because 76% of the population was screened with a colonoscopy. In Germany, a national study demonstrated that colon cancer instances dropped significantly by 25% due to screening colonoscopies. This is the conclusion of the German study. In the province of Ontario in Canada, the incidence of colon cancer has dropped similarly by about 25% over this period of time, again due to screening with colonoscopy of some of our population. Unfortunately, other countries that recommend fecal tests have not seen any significant change in their colon cancer incidence. As you can see from this slide, new cases of colon cancer have been steadily declining in the United States related to colonoscopic screening. The most telling statistic is what doctors do. I can tell you that the vast majority of doctors like myself opt for colonoscopy. This is why you should too. This is what I tell my patients when this comes up in discussion. I often tell my patients when I have removed polyps from their colon that it's impossible for me to know whether I've prevented them specifically from not getting colon cancer. But I know that some of the patients that I'm removing polyps on, this is definitely the case. In summary, colonoscopy is our best test for the detection of precancerous polyps and colon cancer. Colon cancers are prevented with the removal of precancerous polyps. The benefits of colonoscopy greatly outweigh the risks. Screening colonoscopy at 50 in average risk patients is cost-effective compared to other tests. The take-home message is that all patients should be encouraged to have a screening colonoscopy. Obviously, if they're not willing, they should be offered FIT testing. Some screening is obviously better than no screening. and that's why we recommend fit testing to those that do not want a colonoscopy. Thank you for watching this video on colonoscopy screening in average risk patients. You've been watching Medicine with Dr. Keith Moran. If you learned a lot from this video, click like, subscribe, and click the bell for notifications. I'm Dr. Keith Moran. Get healthy and stay healthy.